Okay, so we have Carolina. Come on up.
Thank you. And I'm Kimber Walters with Carolina's Healthcare System. With me is also Jennifer Paracci, one of our clinical managers, and Lynn Bailey O'Neill, who has come to us from one of our physician offices. And we were the fortunate group that got to do the presentation first before the new rules, so that was fun. And I'm wondering first, did anyone see anything on Annette and Kathy's presentation that you haven't already experienced? Yeah, no, all right. So I think what you're going to find in our presentation and potentially in the others is that we're all kind of facing the same challenges. And how do we go about fixing this? So let me tell you a little bit about Carolina's first, and then the people who really did the work, they will come and talk to you. We are a healthcare, home health agency that is an LLC owned by Carolina's Healthcare System. In our area that we serve, we have 8 acute care hospitals and with approximately 2,000 beds. We have over 1,400 CHS family practice and internal medicine physicians alone. And if you have any idea what that is like, you know that that is a huge challenge. We have 5 Medicare certified licensed home health agencies covering 16 counties in North Carolina, pretty much from Asheville to Wadesboro, if you know anything about North Carolina. And our average daily census in home health is about 2,000 patients. 70 to 80% of our census is Medicare or Medicaid, and our referrals, 70 to 80% comes from the hospital, which means 70 to 80% of those need face-to-face. So this sounds probably like a lot that you're experiencing. We had incomplete or inaccurate face-to-face documents with nearly $1 million in held claims. $300,000 plus were just written off in 2014 due to incomplete or inaccurate documentation. I see some heads going, there, I'm there now. Hours upon hours of teammate time attempting to get corrected documents. The current state, ours looked similar to that, only messier. And it was everyone chasing the same thing throughout, hours upon hours. We had clinicians not working at the highest level of being a clinician. They were working at grabbing that face-to-face document somewhere along the line. That included orders management, sales team. How many of your sales team is really tired of not being able to sell? And what they're doing is trying to get face-to-face documents. And that idea that this is an opportunity to talk to the physician, they're not buying it anymore. Our clinical managers were going through documentation to make sure that we had it. Our regulatory compliance RNs were sure that everyone ahead of them was doing nothing about face-to-face, right? What is it with you people? I know. We had frustrated MDs and other referral sources, and quite honestly, we didn't see an end in sight. So when Palmetto came to us and said, hey, we have an idea, let's work together, and we said, we'll do anything at this point. We have been fighting this battle since 2011, and we don't have the answer. So if you could help us with this, we are more than happy to be part of that. So these are some of the people that we got involved in the project, the team. From operations, myself, Jennifer, we had central intake involved, we had team assistants, we brought in a physical therapist who also is involved with our documentation. We had orders management, we had regulatory piece, billing, we had sales. Then we had support operations. We have our own lean facilitator. We had corporate compliance. We had physician corporate compliance. Amazing what the physicians don't know. We had our transition liaisons from the hospital. We had IT there. And then we brought in a couple of referral sources. Now, I will admit, the physicians' practices were not real excited about participating in this. We were very fortunate that Lynn came on, and she will tell you why she came on, and I will tell you it was eye-opening for us to figure out, to learn what they're actually doing in the offices. It's not what we think they're doing. We also had Joan McSweeney, who is a case manager at the hospital and now one of our greatest supporters on the hospital side. And then we had Dr. Rissmiller, we had to go find him, who is head of the hospitalists. He doesn't come to you, you go to him. So here's an idea of what it looked like when we started, and you can see all of our little pink and yellow and blue all over the place, and that is our process. What we found, and to kind of give you an idea, is it is true, every one of us is doing whatever it takes to get it right, but each of us are doing whatever it takes to get it right. And so we were all on top of each other, and we just kept adding processes to see if this might work, and never really took anything away. This was our baseline map. It looks kind of like that one, only not as neat. One of the things that they learned through this process since we were first is that white paper doesn't work as well as brown paper, apparently. And you can make it neater. We weren't so neat. We found 200 waste opportunities, 200 in our process that added no value to the claim or getting it right. 100 action items were identified. I can tell you we have not done 100 action items yet, but 100 action items that we needed to do to clean this up. This is our future state, and it looks kind of like that in the back, with all of those green little things that we need to do. We also felt it was important to solve the problems of the world, so you will see on this far side all of the things, if we could fix the entire healthcare system, this is what we would do. Fortunately, Kathy and Annette told us to put that off to the side. So we have not fixed that yet, but that's what we are looking at if anyone gets to make me queen. That will be the first items I get to. So what we did, 4 initiatives essentially. Create a central expediter process to manage the process. Standardize acute facility documentation to include guidance and face-to-face requirements. Standardize the ambulatory physician documentation to include the guidance and face-to-face requirement, and educate the ambulatory physicians. We moved the standardization of ambulatory physician documentation and education up in priority over the acute care. For those of you who are not part of a system, it really is not quite as easy to get the attention of the people in the facility in the system as you might think it is. So we decided that with the removal of the narrative, we would require extensive work redesigning the acute facilities. They don't really want to do that. And it was, so because of their system, because changing the electronic documentation in an acute care facility is huge, and has a lot of needs and multiple departments, we decided that probably was not a good idea. The other thing is, and this may be happening in your systems, whether you know it or not if you're external, is that there's a lot of initiatives now on length of stay and readmissions that are trying to connect the system to the community physician. And we decided that that was an opportunity. Since some of those things are already happening, that was an opportunity we were going to take advantage of.